Good morning.
I'll give it a minute or so. We're a little bit early. All right, I think we have hit a quorum, so we can get going. All right, good morning, everybody. So much shorter one than usual, but we'll move forward. Okay, starting with this first case, why don't I ask Dr. Barris what he thinks about this? This is a 16-year-old who had surgery for tetralogy absent pulmonary valve, and this tracing was obtained 15 years later. So what do you think is the defect or the problem here?
All right, so first I'm just kind of looking at what leads we have on the right here. So we have a few regular electrograms. We have a distal right atrium, proximal right atrium, His, and then RV. And then what I'm seeing on our first deflection.
So Dave, before we go any further, what are we missing that we normally would have in an EP study, just for completeness sake?
Coronary sinus.
That's right. We don't have a coronary sinus lead, but that's okay. They can give you whatever, when you're asked a question of this nature, they can display whatever you want. But you are doing great in first looking at the legend on the left-hand side in order to identify what the leads are. So that's critically important. So I'm sorry for interrupting. Please proceed.
Okay, so now I'm just kind of looking at the first deflections that I see. I see deflections on the regular ECG leads and in the distal His, but then I'm not seeing that come through to the proximal RV. In fact, I'm not really seeing any deflections at all in the proximal RV throughout this tracing that we have here.
Okay, good point.
And then otherwise, just kind of moving forward on the tracing here, I see a tracing, small deflections on our 1, 2, and V1. And then now I'm kind of looking at our other leads here. Right atrium is first, then proximal RA, then proximal His, and then distal His. Not really seeing a second deflection until so perhaps this is, the atrial, our atrial impulse that's then blocked, because I'm not seeing a second, what would correspond to a QRS complex. And then I'm seeing, we're having some gap of time until I'm seeing another impulse in 1, 2, and V1 that again corresponds to all of those deflections in RA and His. But then this time I do see what looks like our I do see what looks like our QRS complex, um, but there's no corresponding QRS in RA, electrogram, and proximal His. But I do see something in distal His this time.
Would you normally see a ventricular electrogram in the high RA channel?
No, I suppose not, because that would
Not
be an
always.
atrial.
Right.
Um, so perhaps this is, we're dealing with some sort of heart block here because not all of the atrial impulses are being conducted. Um, the question is this a 2-to-1? Is it, I
Well,
feel
it's
like,
hard to tell because I haven't given you enough beats to know.
right.
Although I agree 100% with you that here's an A and here's an A and there's only one QRS. So at least for the beats you've seen, it does appear as if there are two A's for every V. And also this A also doesn't obviously appear to conduct to a V looking at the QRS. I also might add that there's something wrong with this RV channel, right? Because it has nothing on it, but we clearly see that there's a QRS. So this is a faker. I put the
Mm-hmm.
channel here, but there's nothing on it. So yes, it appears as if it's probably 2-to-1, although with only 3 P waves, it's very challenging to know, obviously. But I agree that that would be a high level of suspicion for that. What kind of so not all the P waves are conducting. So where is the block, David?
So even though all the P waves are not they're not conduct even though the peers are not conducting, but I see in His that there is, so it probably is somewhere in the AV node if we're below that, because we're already seeing a His deflection.
So if you so when you're looking, so here is an A, a His, and a V. So which of these corresponds to AV nodal conduction? The time it takes to go from the A to the His, the time it takes to go from the His to the V, or the time it takes to go from the A to the V, which is AV nodal?
I would say the AH.
You would be correct. And so then where is the block here?
So in that distal His, I feel like I do still see that His deflection, and it looks like the AH is pretty much the same.
Mm-hmm.
So I would say it's after that.
Right. So we would say it's infrahissian, meaning below the level of the His, because we are conducting to the His on every beat, right? Here's an AH, no V, AH, V, AH, no V. So this suggests then that the injury is at the level of the His-Purkinje system, and that is generally a higher degree of block. The lower you have the block in the conduction system, the more serious and concerning it is. And most patients who have postoperative heart block have block at this level, at the His-Purkinje level, not at the AV nodal level. Okay. And so this would be a concerning finding in someone who had open heart surgery because it implies that there's been a significant injury and could be a concern for future conduction. So this would be, I guess you could say, 2-to-1 block that is infrahissian at the level of the His-Purkinje system. Okay, good job, David. Okay, this is we had 2 of these left from the last conference. This is another text message from a fellow. Hello, Dr. Pass. This is blank, fellow at Sinai. Had to identify themselves to me. How are you? Didn't get a chance to meet you since you started as I was on vacation. I'm on call. Have a question about a baby following truncus repair. My understanding is that he had PACs and ectopic atrial tachycardia and was started on amiodarone loading, and this is his 5th day of loading. He had frequent episodes of sinus bradycardia to the 80s and 90s. He's otherwise hemodynamically stable. Wondering how long we should load and when we can switch to maintenance. This is the This is the tracing. And let me ask Jenna. I think you're on the line. Dr. Keelan, how are
Hello.
you? Good morning.
Good
So
morning.
you came here for non-invasive imaging, and we're going to torture you with electrophysiology. But this is good. It's the last time in your whole life you'll have to answer a question in this level. Um, so how long would you normally load somebody in whom you're starting amiodarone? And each day we get a 12 lead EKG. So what are we looking for each day when we do this? This is the 12 lead that the former cardiology fellow was kind enough to send to me.
hmm Usually we would do a 5-day load of amiodarone. I think is pretty
Okay.
standard. Um, and obviously you want to see, the reason why you started it, if he's still having that tachycardia or not, or if it's improved, um, as to whether you would, continue to load further or not. Um,
Now, how would you load, Jenna? Let's say the patient initially was in EAT and was, say, post-op day 1 and was NPO. So
mhm.
how are you going to load this patient?
Um, So you can do amiodarone IV.
Hmm.
Um, I think it can be associated with some hemodynamic instability.
Okay,
Um,
since you brought that up, what are the concerns about the hemodynamic instability? I agree with that statement. It can be associated with some hemodynamic stability, to use your terminology.
mhm.
But what exactly is that concern?
I think it's the diluent that it's uh,
Hmm.
produced in. I forget the name of the actual
Uh-huh.
compound, but
It's an alcohol base. So
mhm.
what is it that can happen, and how concerned ought we be about it?
I think so. It can cause like basically like hemodynamic collapse. I think um,
Hmm.
like at the time when the first dose is given,
Uh-huh.
and I think it's more of an issue in neonates.
That's exactly true.
Hmm
And I believe that it happens something on the order of 1 to 5% of patients.
hmm
Is there anything you can do to try and prevent that?
I actually had heard that they're producing it in a different solution. That they're coming out with a new formulation of it.
Okay, that
Is
might be
that
true. I
okay?
don't know the answer to that. I can tell you that the only large-scale trial of IV amio was actually with a formulation called aqueous amiodarone, where they did not use the diluent and they still had the problems, actually.
Mhm.
Um,
I think
probably the best thing is to give it very slowly,
right.
and upon noticing any hemodynamic embarrassment, to consider changing it or not. And it's important to remember that amiodarone is actually one of the more potent negative inotropes, which is interesting because it has traditionally been used because it was thought to not be particularly important negative inotrope, but more recent data suggests it's actually pretty significantly negative inotrope. So it can be used, but you have to be careful. Okay, so you start the IV amio. The IV amio did not cause cardiovascular collapse, or else we wouldn't be talking at this post-op day 5. And we've now been on IV amio for 5 days. So you say you're the attending on. Uh, your fellow, Dr. Kong, says, how long do you want to keep it on? Dr. Keelan, and you say, okay, this is the 5th day. Let's stop loading. So how much do you want to give, and how are you going to do it, and how are you going to transition from the IV to the PO version?
um, I would. I don't know the numbers off the top of my head, so I
That's
would
okay. You
look it
can,
up.
okay. So well, how much should you be loading with when you load with
um,
amiodarone?
I think it's is it 5?
So for SVTs, we
Uh,
generally load with 10 per kilo per day.
10. Okay.
And for VTs, we generally load with 20 per kilo per day. That's the loading dose, not the chronic dose. And the chronic dose is half that. So for SVT, we typically will give 5 per kilo per day. And for ventricular arrhythmias, typically closer to 10 per kilo per day. So we're treating an EAT, and we are now on 10 per kilo per day, IV. So you instruct Dr. Kong, the fellow, to switch to 5 per kilo per day. We are now extubated. We are feeding. So how do you make the change from the IV to the oral formulation?
I mean, so amiodarone I know has a long half-life, so I don't think it needs to be like particularly precise. I would probably give because it's when it's given IV, we dose it. Is it Q12 or Q8?
Well, when we give it IV, normally it's given as a
Mm-hmm.
continuous infusion.
Mm-hmm.
Although you have to be careful with IV amio because it has to be given through special tubing because amiodarone can leach toxins out of plastic tubing. So it's typically in a glass bottle, and the tubing is also special. But let's assume for the sake of this
Yeah.
discussion that has been done properly by the nursing staff, which is usually the case. So
So yeah, in that case, I think I would probably just stop the infusion and then give the first dose of the oral.
Okay, so this is an important point, which is that the IV formulation of amio has a much shorter half-life than PO. What is the half-life of PO amio, Jenna? You hinted that it was very long. How long is it?
I think in the order of like days to weeks.
Yeah, it's actually about a month and a half, about 45 days. So it's very long, um, which is why we give twice the normal dose when we're loading, because we're trying to get the level up as fast as we can. But the point I'm trying to make is because the half-life of IV amiodarone is much shorter than oral, it is routine to have an overlap of both the oral and the IV. And so normally we would give roughly 2 days of oral while slowly lowering the IV to allow for a crossover between the two. If you were to stop the IV and start oral, there's a reasonable chance that the arrhythmia will recur. So you do need to have an overlap between the IV and the oral. And so during that overlap, we typically will just have the patient on double the dose. So if you're on 10 per kilo per day, then we'll give 10 per kilo per day IV while we're giving 10 per kilo per day oral for a day or two. Maybe cut the IV in half, halfway through that, and then stop the IV. So that's an important clinical point, that you need an overlap of the IV and the PO. Okay. Very good. Let's move on. Okay. This was a text from a fellow who used to work here named Uzoma. And this says, this is second patient. This was a day which we saw newborns who we were told had murmurs, but Dr. Uzoma says that we didn't have a murmur. And she notes that the QT appeared to her to be prolonged to 484 milliseconds. Would you like to see in clinic in 1 week for follow-up EKG to follow up the QTC? So this is the tracing that Dr. Uzoma asked me about. The question that's being asked is, what would you like to do about this? And I think I'll ask Dr. Babia what his thoughts are on what he would do. If I agree with Dr. Obiaka, who said that this was in fact a long-ish QT interval. So Sergey, you're on call. The Well Baby Nursery wants this kid out because they need the bed. So what are you going to do about this? Because QT, I think we would agree that if Dr. Obiak is correct in her assessment, which we have established she was, that the QT is 484. I think we would agree that is definitely a long QT interval. So what are we going to do about a newborn who has a QT of 484?
Well, first we'll get a good family history, asking about any sudden cardiac death.
Right. Excellent. That's very good, very important. Let's assume for the sake of discussion that the history was negative, which in fact it was in this case. But that is a critically important question. So thank you. And so now you know that. Now what would you do?
I would ask if I wonder if mother could be on some kind of medication that would prolong the QT in the baby too. Is that
It's
possible?
not, I think that is possible. I've never seen that, but it kind of makes sense that that's possible. But the mother is a health nut. She's very organic, and she is not taking any medicines at all. It was a natural childbirth.
And the child, I suspect, is not on any medications either, right?
The child is not taking any medications, just being breastfed. Baby is 36 hours old. And OB has now paged Dr. Obiaka 3 times that they must get this mother out. But she can't find me because I am not answering my page. So what is she going to do?
Well, since I'm not sure, I would probably keep the baby for another day and repeat EKG and
Okay.
see
What
how
are
the
you
QT.
what are you looking for in that EKG the next day?
That the QT is shorter rather than longer, or
Okay,
the same.
that's reasonable. All right, so we get the EKG the next day, and this is the EKG. Now we are now 54 hours old, or whatever, 60 hours old, and you have this EKG. So, what do you want to do about this?
Well, let me read the EKG besides the QTC.
The EKG is completely normal with the
Right.
exception of the QT. I'll read it for you, but thank you for that offer. Thank you for that feint. In boxing, they'd say that's a feint, moving to the left or the right. It's avoiding the punch. But
Well, for the sake of saving the time, I'm not sure
right.
how.
So the point I'm trying to make is that newborns will often have a slightly elevated QT interval. Um, and so I don't know that it's established why that is, but newborn patients will sometimes have a longer than average QT. And so, generally speaking, in a patient who is asymptomatic, who has a negative family history, and whose QT is under 500 and has a relatively normal T wave morphology, we would usually not start therapy on such a patient. We would watch it and have them come back between 2 and 4 weeks of age, because usually by about a month of age, the QT should normalize if that sort of newborn slight prolongation in the QT is still it was present, that is not representing true long QT syndrome. So normally in a patient like this, we would usually send them home on no therapy with a relatively soon follow-up, perhaps 2 to 4 weeks, to repeat the EKG and look at the QT interval. This is something that comes up quite frequently when you're in practice. And in fact, this ECG normalized when we saw the patient 2 weeks later. There was a normal QT interval. Now, there are rare times where the QT is so long that we treat it anyways. And one or two of you may have been on call with me. We had a patient a few months ago now, who had a QT that was like 540. And when it's really long, we would not anticipate that's going to normalize to a completely normal level. And so in those cases, we would treat with beta blockade. But in this case, because it was on the borderline of normal, remember again that girls are allowed to have a QTC up to 470. So this is only a little bit longer than the 95th percentile, or 2 standard deviations, a little more beyond 2 standard deviations. So we decided to watch, and thankfully we didn't get burned with that decision. Okay, let's move on here. This was from a Zeo patch that I was reading last week. And why don't we ask Dr. Perner Bonsall of the Upper East Side of Manhattan, what she thinks about this tracing, what she would do about it. This is a 3-month-old that had this tracing.
Good morning, Dr. Bass.
Good morning, Perna.
What's the history?
The history is that this is a 3-month-old who had a Zeo patch.
Why
Who
was
is-
it done?
Who is asymptomatic because there was some concern about some fetal arrhythmia. But unfortunately, the ordering physician is on a plane to California. As a result, we are unable to get the full history from that doctor.
Mm-hmm. Okay.
She would like to answer the question, but she is watching a movie in first class and cannot answer her cell phone.
Sounds like a good life.
Yes.
So
One day that life can be yours.
I wish. So initially, I see every P wave being conducted, but towards the middle of the strip, that one beat is not conducted, and it reflects in the other strip beneath the bigger strip,
Mhm.
and then again all the P waves are being conducted, and then if I correlate with the strip underneath, it
Mhm.
starts to look sparse. It starts to look sparse.
Now, starts to look sparse. This is a terminology I'm unfamiliar with. I don't know what you
Like
mean by that.
the
You mean
beats
that it's
seem to.
happening infrequently? Is that what you mean by that terminology?
I meant that the heart rate has decreased. It seems like, and it seems,
Mhm.
and then there is one P wave that's not being conducted, and then every other P wave is not being conducted in
You're
the
speaking of this lower tracing here.
right,
Yeah.
right,
I think that
yeah.
what they try to do in this particular company, which is Zeo, is they
Mhm.
show you this is basically what was happening around the time of this blown up tracing here. But yes, okay, I agree. It
So
does
these are
appear.
simultaneous. These are
I think
simultaneous.
that they're not. This is, I believe, representing this. And
Okay.
then they're showing you, like, let's say 5 to 10 seconds before and 5 to
Mhm.
10 seconds after.
Okay. So in the latter part of the strip towards the end, if the underneath the smaller strip shows, as I said, a P wave after every QRS, but some of alternately they are not being conducted.
Mm-hmm.
I don't really see the same deflection of the P wave in the blown up strip. The blown up strip continues to show whatever the prior beats were, and it seems like there was only one non-conducted beat in the blown up.
Mm-hmm.
Um,
So you have a non-conducted P wave. We're referring, of course, to this P wave. So
right.
what is this? What type of, so this is a block of some sort.
Mm.
How
So
would you characterize this heart block that we're noticing?
I would say type 2 block, heart block.
Is
Uh,
that first, second, or third degree that you're referring to?
second degree heart block
So it's second degree heart block, and you are positing that it is Mobitz 2
type.
heart block. Is
Mhm.
that right?
Mhm.
And why are you suggesting that?
So first degree heart block, we would have only PR interval prolongation without any drop beats. So
Which we
that
do
is not
not have.
C.
Yes. Okay.
And then or we could have like increasing, progressively increasing PR interval, and then one beat being non-conducted, which is
Yes.
also not the case. We are
And what would
abruptly
that be,
dropping.
by the way?
We'll call it Wenckebach or Mobitz type 1.
Second degree Mobitz type 1.
Mhm.
Yes, I would agree. And that is not what appears to be occurring here, right?
And then we have suddenly and then without any apparent PR interval change, one of the P waves is not being conducted. That's why I'm calling it Mobitz type 2.
I agree with you. Okay, so you do the tracing, and I agree with you that this suggests on the bottom here that there may even be some 2-to-1 of this nature.
Mhm.
So what are you going to do about this 3-month-old? How do you want to work this patient up? Or
Um, would like to get family history, any maternal history
okay, the
of
mother,
any.
you've pulled the mother in. She has a malar rash. You ask her, does she have lupus? She says, no, I've never had lupus. I just have ruddy cheeks. So what would you
Um,
do?
so I mean, again, we can talk to her more about her history. If she definitely has been worked up or known about SLE or Sjogren's. Also, what was the baby's newborn screen like? Was there any concern? Or
She's sipping on a bottle of water because she has very dry mouth.
the baby or the
No,
mom?
the mother.
Yeah, I think she needs to be worked up for Sjogren's
Okay. All
syndrome.
right. So let's say the mother does have Sjogren's syndrome.
I would check for antibodies in the baby for Rola.
Okay. So actually, I think normally we check in the mother, but okay. So there are antibodies, and this is what you found. So what would you do for this patient?
Mm.
So you have an
We've established
explanation.
we've established the cause now.
That's right.
Um, how often is it happening on the Zeo patch?
It happens infrequently. There are 7 episodes of this, let's say, throughout the 24 hours that it was worn.
Mhm.
The average heart rate is 123, maximum heart rate 172, lowest
Um,
heart rate 65.
I would put in a Zeo patch for a longer period of time and see.
Okay, you've now done a 14-day ZO.
Mhm.
The average heart rate is 122. The maximum heart rate is 173, and the lowest minimum heart rate is 65.
Okay. I would continue to watch.
Right. So
Yeah.
the short answer is we would not put a pacemaker in for this.
Hmm.
We would just monitor this. But, sometimes you have to be a little more careful with people with second-degree heart block than third. It seems counterintuitive because it's
Hmm.
a lesser degree of block. But the problem when somebody has second-degree block is that you don't actually know how is it going to progress. This is something that Dr. Hardoff, who's a senior cardiologist at Columbia, now retired, but still gives lectures. I think Dr. Keelan probably is familiar with Dr. Hardoff from her days at Columbia.
Yes.
And Alan used to always say to me that he used to be more bothered by this type of finding in a baby because thing is when you have complete heart block, we have lots of series and studies on the natural history of complete heart block, and complete heart block in an infant usually is extremely well tolerated hemodynamically, and we know the natural history of it, which is that generally it gets slower over time, and eventually patients need pacemakers, but it is rare for the Holter to change substantially in a relatively short period of time. But when somebody like this has second-degree heart block, particularly Mobitz 2 block, which is a higher grade of heart block, we don't actually know what the natural history should be because this is a somewhat unusual presentation of it. And so we don't know if this were to progress to third degree, what the heart rate would be in third degree in this patient. We also don't know if this is going to progress to third degree. So it is certainly something that would require continued observation and monitoring over time. Okay. All right. This is a patient that I saw in consultation who at another hospital, 6 weeks old, had a history of SVT. And I saw the patient. They were on flecainide, receiving, I believe, 60 milligrams per meter squared per day of flecainide and propranolol, 3 milligrams per kilogram per day. And this is the Zeo patch that I received. And so I just wondering, why don't we ask our good friend, Dr. Grace Kong, what she thinks is happening here. And while we're here, I'll just wish a good morning to Lynn Napo, former electrophysiology nurse, now retired, but still interested in EP. Welcome.
Good morning.
Good morning. All right, Grace. So what do you
Good
think
morning.
is going on here?
Looks like we have a neurocomplex tachycardia. The rate is somewhere in the high 200s, 252, high 200s, I would say.
Mm-hmm.
I don't see readily a P. Actually, I don't. Yeah, I don't readily see a P wave that I'm confident about in the tachycardia to tell you what I think the mechanism is, but does seem reentrant.
Why do you say it's reentrant?
It's very regular.
Mm-hmm.
The intervals are very regular.
Okay. Anything else make it seem reentrant? I agree with that statement, by the way. Just
At the very end, when it terminates, I feel like I see a P that comes in, possibly, I guess, like a PAC that terminates it. And so that would argue for reentrant tachycardia as well.
well, I think just the mere fact that it terminates so suddenly, right?
Oh, yes.
Automatic arrhythmias do not terminate this suddenly, virtually ever. So the fact that it is very regular and that it terminates so suddenly would be strongly suggestive of it being reentrant. So I agree with you on that. Now, if I just told you I have a 6-week-old who has a heart rate of, let's say it's 250 here, what is, without even looking at the tracing and that it's narrow QRS, what is the most likely statistical thing that this is?
ORT.
ORT, or orthodromic reentrant tachycardia. So when I look at tracings using the knowledge that I have about this, I try to convince myself or of whether it possibly is or is not. And so it's most likely ORT. What percentage chance are you, if you were to guess ORT without even seeing the tracing, what's the likelihood that it will be ORT?
I'm guessing about 40%.
No, it's actually about 70 or 80%
Oh, wow.
of babies who have SVT is ORT. Okay. AVNRT is about a quarter, but about 3/4 is ORT.
Okay.
And the only thing I would say about this is that if you look at the T wave here, just before it terminates, there seems to be this sort of unusual notching. And if you look at this beat here, which is a sinus beat, I don't actually see that notching. Here we do see the notching again, but this could be re-entering up. This could be what we call an echo beat, meaning you go down the AV node, you come up the pathway, but then it does not conduct back down again. So I don't know for sure, but I think if you look at many of these beats, you could convince yourself that there is this unusual inverted sort of double hump on the T wave. If that were in fact a retrograde P wave, would that RP interval be consistent with a pathway?
It's quite long, even for a ORT. I don't know what the cutoff is for PJ.
I see. So it could be
Yeah.
PJRT, but it's not that long. It's about
Okay.
200 milliseconds here. So anything over 70 milliseconds, right, would be consistent with possibility of ORT. Okay. I will also tell you, just for the record, that the patient is intermittently pre-excited.
Okay.
So this is a pathway. First of all, anything about the therapy that might explain why the patient is intermittently pre-excited?
I'm not sure.
So
No.
flecainide can cause pathways to stop conducting. That's actually one of the main reasons we use it for people with ORT, is it's very good at blocking accessory pathways. So just like it can block it retrograde, it can block it antegrade. So in some patients, if you start flecainide, you will actually lose pre-excitation, which is often a good indirect sign that the medication is being effective at blocking pathway conduction.
Mm-hmm.
Okay, so the patient is on flecainide and propranolol, is on 60 milligrams per meter squared per day of flecainide and 3 per kilo per day of propranolol. What would you do based on this finding?
Mm-hmm. We're terminated at this point, so we're trying to adjust our maintenance doses.
Well, that's a possible option if that's what you choose to submit as your answer to this question.
Okay, let me think about it. 6-week-old.
I'm not agreeing or disagreeing. I'm just clarifying what you're saying.
6-week-old. We could
So
try a different
we,
medication.
you could. So what medication would you like to try?
He's a 6-week-old.
Mhm.
Could we do amiodarone?
Yes, you could. How would you, if you wanted to start amiodarone, how would you do that?
I think I would do a PO loading
Mm-hmm.
and then transition to a PO maintenance.
So the patient has come from outside. They live in Brooklyn. They're here for a second opinion. So how would you do that? Would you do that as an outpatient?
I've never seen anybody admitted for a loading amio, so I would think so.
No, actually, we would not load amiodarone as an outpatient, even though it does have a
Okay.
very good track record of being safe. I don't think anybody feels comfortable starting someone on amio as an outpatient. So we would have to admit the patient. So that has some implications.
Mm-hmm.
The family is like, admit to the hospital, doctor? Absolutely not. I heard there's COVID there. So what do you think about this dose of 60 milligrams per meter squared? Is this a high dose, a low dose, a medium dose?
I think it's a medium dose.
Actually, the starting dose for flecainide is anywhere between 50 and 80 milligrams per meter squared per day.
Okay.
So this is not a particularly high dose of flecainide. And so, so what I did was I asked to increase the dose. We went up about 15%. Any special precautions you have to tell the mother in regards to flecainide?
You have to mix it very well.
You have to mix it well because why is that?
Because the way that it comes, when it comes compounded, it's not evenly dispersed throughout the solution itself. So if you just give it without mixing, then you can get more or less of the desired dose.
Right, that's true. And so the other thing to remember, of course, is flecainide has a very narrow therapeutic index. So too much is not a good idea. Okay, so what we did was I weight adjusted the propranolol, and I increased the flecainide to, I think I actually ultimately went up to 90 milligrams per meter squared per day. And I have a repeat ZO pending, so we'll see if we had control. We also are looking on the repeat ZO to make sure that there is not any ventricular ectopy, which can be a sign of toxicity of flecainide. It's very important to keep very close tabs on that. So we'll do one more tracing here. This is a 12-year-old who has an ambulatory recording. This is another ZO patch. And I'm going to ask Dr. Neha Luwalia, who has somehow escaped any questions this morning until this moment. As you may remember, ZO actually uses artificial intelligence to interpret their tracings. So, do you agree with the artificial intelligence of this computer, or do you believe that your intelligence exceeds that of the supercomputer, Dr. Luwalia?
Hi, Dr. Paz. I
Good
thought I
morning.
got lucky today. Good morning, but all right. Okay, so the first beat, I don't see a P. The second has a sort of prolonged. The third beat, don't know if that's the actual conducted beat, because that would be a very, very prolonged PR.
I think we can assume that if there's a full second between the P wave and the QRS, it is not conducting.
Right.
Might be
And
wrong, but you would mostly be right if you always assumed that in that setting, but yes.
right. And then again, you see one conducted, the second one isn't, and this is continuous, I'm guessing. So on the lower beats, you have 3 that are conducted and then a block. So I don't think it's 3rd degree heart block. I'm trying to see if I can convince it's Wenke backing.
Well, I think
But
it's hard to tell. I mean, it's
yeah, it's
possible
hard.
that you could argue that in the lower tracing that this is some example of Wenke-Bach, but I think the point I'm trying to make here is you are correct. You are, in fact, smarter than the supercomputer. Dr. Lawalia, good job. I knew that, of course. But the important thing is that, you know, when people are in complete heart block, the first thing you always want to look at is to look at the R to R interval, because people who have complete heart block rarely have anything other than a relatively fixed R to R interval. There may be very minor variations in the R to R interval, but in a strip this short of 11 seconds, you would expect the R to R interval to basically remain the same, or at least be relatively fixed, and it is not. This P wave does appear to be conducting in some manner because this R to R interval is shorter than this R to R interval, as is this R to R interval different than this one. So the mere fact that there is some conduction is demonstrated by the fact that the R to R interval is not regular, because these 2 beats are probably being brought in slightly earlier because there is some AV conduction, albeit poor. And the second tracing, of course, confirms that, because I agree with you that these 3 beats do seem to be conducting, whereas this one is not. This is just a junctional escape beat, and then there's a conducted one, and then a P wave that's not conducting. So this would, I think if you were going to interpret this tracing, you would say this is evidence of high-grade 2nd degree AV block, suggesting that artificial intelligence is not quite there yet. I'm sure it will exceed us very rapidly, but it isn't just there yet. And so with that, I think we'll end it for today. Thank you very much. And I will see everybody in a few minutes at sign out. So thank you, guys.
Thank you.